This is Dr. Priyadharshini and I welcome you all to RRR Series for EBCOG Part 1 examination. In today's session, we are going to see on postpartum problems. Be proud of how hard you are trying. You've been trying sincerely and dedicatedly all this while, and this is an attempt by StudyMEDIC to help you prepare better for your exams. So today's learning objectives are going to help you understand the exam format and approach to EMQ and SBAs. The module that we have taken for discussion today is postpartum problems. So we will start off with some questions. We have a 29-year-old primiparous woman who was brought to the emergency department 10 days postpartum by her husband. She reports she has been behaving erratically. She has been experiencing severe mood swings, paranoia, and auditory hallucinations, where she hears voices telling her that her baby is cursed. She's also been neglecting self-care and refuses to breastfeed, saying that she's been watched. Her husband states she has no past psychiatric history, but her mother had postpartum psychosis. Her physical examination is unremarkable. The basic investigations, including infections, are all normal. So what are the important clues we pick up from here? One thing, it is postpartum. Second thing, it is psychiatric illness. Most important keywords that are going to lead us to the diagnosis are auditory hallucinations, not taking care of the baby, and also she says that her baby is being cursed, and the giving a mother having history of postpartum psychosis. All this together give us the diagnosis of postpartum psychosis. But what is the most appropriate next step in management? That is what we are being tested on. Now, whenever we have postpartum psychosis, we need to understand that this is an obstetric emergency. So what are we going to do for this? We have to immediately admit her to the mother and baby psychiatric unit. Understanding psychiatric problems in the postpartum period is very important because we cannot miss on some diagnoses such as postpartum psychosis, which needs an emergency multidisciplinary team to take care of the mother and the baby. Now, what are the differential diagnoses we can think of when we're dealing with postpartum problems? There can be prenatal depression or anxiety, which can continue into the postpartum period as postpartum depression or postpartum anxiety. It can be related to any traumatic events like a post-traumatic stress disorder, obsessive compulsive disorders, bipolar disorders, and most importantly, not to forget postpartum psychosis. The most common problem that a woman faces with relation to the psychiatric illness is called as postpartum blues. Though this postpartum blues is generally not classified as a psychiatric illness, the woman generally has a low mood and she seems to be a bit irritable and depressed. However, she gets corrected with some counseling, and generally a psychiatric intervention or medication is not required for postpartum blues. One major thing to note is in postpartum blues, she takes good care of the baby and she is also well cared of. All she needs is a little bit of support and rest in postpartum blues. Whereas when you come to postpartum depression, the woman is depressed and she might need additional medications or a psychiatric counseling or therapy to control her postpartum depression. Women with postpartum depression can or cannot have may or might not have a history of antenatal or antepartum depression. A psychosis, as we just saw, is taken as a psychiatric or an obstetric emergency, and she requires an immediate intervention in these cases. In obsessive compulsive disorders, usually the mother has a history of depression or anxiety, and she does some actions repeatedly without any conscious thinking of the actions. Others can be bipolar disorder or postpartum onset of panic disorders. In panic disorders, the woman is always panicked even for very small events. In bipolar disorders, there are episodes of mania and depression which keep interrelating. Post-traumatic stress disorder can be related to traumatic childbirth. It is usually following a difficult forceps delivery, a stillbirth, or a crash or category 1 cesarean section. Going on to the next question, we have a term infant who is delivered by an emergency cesarean section due to prolonged fetal bradycardia. At birth, the baby is limp, pale, and not breathing. The umbilical cord is immediately clamped and the neonatologist is called. The baby is dried and placed under a radiant warmer. What is the next most appropriate immediate step in neonatal resuscitation? Now, if you see here, what are the main points to note? One, it is a term infant. Second one, there was probably an intrapartum hypoxia, which is seen as prolonged fetal bradycardia. Next, looking at the baby's condition, limp, pale, not breathing. So, What are we going to do with the baby? Of course, the first step is already done. The baby is dried and placed under a radiant warmer. Second thing is we need to see the heart rate and provide positive pressure ventilation if needed. This is what our neonatal resuscitation algorithm emphasizes on. The first step is always going to dry warm the baby, and you have to look for breathing and heart rate. Whenever the heart rate is less than 100 or the baby is not breathing effectively, that means the baby is in need of a positive pressure ventilation, and it should be started immediately with oxygen, that is with the room air for term neonates. Now, when do you do chest compression? Only when the heart rate is less than 60 after providing adequate ventilation. Usually, the steps like intubation is not recommended as the first step. Looking at the next question, we have a 34-year-old multiparous woman who undergoes an uncomplicated vaginal delivery of a healthy baby at 39 weeks. 10 minutes later, she develops heavy vaginal bleeding and she's almost soaked 2 pads within minutes. On examination, we find a soft boggy uterus with no vaginal or cervical lacerations and BP is 90-60, pulse is 110. What is the first line pharmacological intervention? So, what are the important points we have to note here? She is a case of postpartum hemorrhage. The most probable cause here is atonic uterus, which is revealed by soft boggy uterus. And what is the maternal condition like? She is going into shock. There is hypotension and tachycardia. So, what do we start with? We have to start with the medical management. And our question is also targeting on what is the first line pharmacological intervention. So we know while going into the medical management of postpartum hemorrhage, we start with oxytocin, and so oxytocin remains the answer. The first step is, of course, oxytocin. If the woman is already given oxytocin, then the second line will be methadone if ergometrin is not contraindicated in her case, followed by prostaglandins where PGF2 alpha can be used if not contraindicated, because it's contraindicated in conditions like asthma. Tranexamic acid is obviously an adjunctive and it's an add-on therapy for postpartum hemorrhage. Balloon tamponade can be done when the medical management fails, and finally the last resort will be the surgical management. So postpartum hemorrhage is very, very important. You need to make the diagnosis whether it is primary or secondary. And in primary, the most common cause is atonic uterus, which is constituting to 70 to 80% of all cases of postpartum hemorrhage. Apart from that, we also have other conditions which can cause postpartum hemorrhage, and they are traumatic PPH. In traumatic PPH, out of cervical and vaginal lacerations, cervical lacerations are more prone to produce postpartum hemorrhage. Apart from that, there can be some retained tissue, retained placenta or membranes, or coagulopathy or DIC, in which the entire coagulation system is affected. Secondary postpartum hemorrhage can be because of endometritis or infection or some pseudoaneurysm involving the uterine artery. Of course, retained tissue can also cause secondary postpartum hemorrhage. The major PPH, the main goal of treatment here is to resuscitate the mother, make sure the maternal vitals is hemodynamically stable, the mother is doing fine, and then we go for the definitive treatment of controlling hemorrhage. The definitive treatment depends on the cause. For atonic uterus, we are going to start with the medical management, the balloon tamponade, followed by the surgical management. For traumatic PPH, we are going to start by suturing the area where it is torn and where active bleeder is present. This is the surgical management of postpartum hemorrhage. Going on to the next question, we have a 32-year-old woman, 2 weeks postpartum, who presents with severe anhedonia, guilt, and suicidal ideation. She is breastfeeding but struggles to bond with the baby. There is no evidence of psychosis. Her Edinburgh Postpartum Depression Scale, EPDS, is 22. What is the most appropriate management here? Here we see that the woman is in severe postpartum depression. There is no psychosis. It is not blue also. Why? Because she is struggling to bond with the baby. So what are we going to do? Are we going to give CBT? Are we going to give an urgent psychiatric review? Are we going to discontinue breastfeeding, ECT, or reassurance and review in 6 weeks? It is not an emergency condition. At the same time, we needn't have to reassure her. ECT is generally reserved for last cases who are not responding to medical management, and it will be decision of a multidisciplinary team. Discontinue breastfeeding? Definitely no, because she's already in depression, and if we have to discontinue breastfeeding, it is going to affect her more. So we are left with two: cognitive behavior therapy or start of sertraline and urgent psychiatric review. Here, sertraline and urgent psychiatric review is addressed. Why? Because she has got suicidal ideation. So this terminology of suicidal ideation needs to be addressed immediately, and hence we are calling in for an urgent psychiatric review. And the use of sertraline is usually the first preferred SSRI in breastfeeding women. CBT alone is definitely not going to suffice because of suicidal ideation, which can be harmful both for the mother and for the baby. Next question, we have a baby who's born via emergency cesarean section for fetal distress with thick meconium stain liquor. At birth, the baby is not crying and has very poor muscle tone. What is the next best step? Are we going to immediately suction the baby before stimulation? Are we going to stimulate the baby and give PPV, administer adrenaline, suction the airway vigorously for 60 seconds, or are we going to deliver the baby? Now, deliver 100% oxygen via face mask. Now, we will have to look back at the scenario that has been provided. Thick meconium stain liquor, emergency cesarean section, and the baby is not crying. That means what? We are going to follow our protocol of neonatal resuscitation. Routine suctioning is usually not recommended even in the presence of meconium stain liquor unless otherwise there is airway obstruction. So we start off with the protocol by stimulating the baby and providing a positive pressure ventilation if required. Now, whenever the baby is not breathing or the heart rate is less than 100, that is the time where we are going to initiate the positive pressure ventilation. These are the steps of neonatal resuscitation. We are going to see at birth what is the condition of the baby. Dry the baby, make sure normal temperature is maintained. You're going to look at the tone, breathing, and heart rate. That means you're going to take the APGAR score of the baby. If the baby is gasping or not breathing, what do? We open the airway, give 5 inflation breaths, and consider the monitoring of SpO2 with or without an ECG monitoring if required. We are going to reassess the baby and see whether the chest movement is present there. And all this process, the steps are going to take only 60 seconds. If the chest is not moving, then we are going to recheck the head position, make sure the airway is patent, and repeat the inflation breaths and look for a response. If still there is no response with the heart rate, we are going to see what is the heart rate like, whether the heart rate is less than 60 or more than 60. If the heart rate is if the heart rate is not detectable or very slow, let's say less than 60, then we are going to ventilate the baby for 30 seconds. If still not responding, then you start off with chest compressions. Going on to the next question, we have a 26-year-old primary woman who develops postpartum hemorrhage due to uterine atony. Oxytocin infusion is started. What additional pharmacological agent is recommended within 3 hours of birth? So we'll have to see that very specifically they have mentioned within 3 hours of birth which additional drug can be used. The drugs that is used for management of atonic PPH need to be used at the earliest. For example, oxytocin followed by ergometrin if not responding to oxytocin and if no contraindications, followed by prostaglandins need to be given immediately for management of PPH. However, the additional drug which can be used within 3 hours of birth is tranexamic acid, which is proven to have a role in postpartum hemorrhage by reducing the morbidity and mortality. Going on to the next question, we have a term neonate who remains bradycardic. That means the heart rate is less than 60 despite 30 seconds of positive pressure ventilation. So what is the next step? So we see the heart rate is less than 60 despite a PPV. That means it is an indication to start chest compression with ventilation at a 3:1 ratio. We have the next question here. We have a 30-year-old woman who reports intrusive thoughts of harming her baby, but has no intention to act on them. She has an intact insight. What is the best management? So this best management here is going to be cognitive behavioral therapy, because this is not psychosis. She's having an intact vision of what she is doing. Going on to the next question, after positive pressure ventilation and chest compressions, that means both the steps are over, still a newborn's heart rate is less than 60. So what do we do now? This is the time for medication. So we start on intravenous adrenaline for the baby. Going on to the next question, we have a woman who has an ongoing massive postpartum hemorrhage despite oxytocin, tranexamic acid, uterine massage, and balloon dampening. That means the medical management is done, the add-on therapy is also done, and also the tamponade. So next step is definitely going to be surgical management. So we start off with a B-Lynch suture, followed by stepwise devascularization, where we start off with the unilateral uterine artery ligation. So going on with some of the EMQs that we may expect. So for EMQ, we are going to follow the cover test. What do you understand by cover test? We are going to read the instructions first. After that, we are going to look at the scenarios, and from the scenarios, we are going to come to a conclusion. Go back to the options and see which option is going to best suit it. So here we have Sarah, who's a 28-year-old preemie. She's presenting at 6-week postnatal with low mood, hedonia, and excessive guilt. She has a very poor bonding with her baby, frequent cry spells, insomnia, and she described like she is failing as a mother and has no energy to care for herself or the baby. She has some intrusive thoughts of harming herself. Her husband reports that she has isolated herself. And frequently she says that she would be better off without her, it means the baby. There's no history of psychiatric illness, but her mother had severe postpartum depression. Basic blood tests are done, the hemoglobin is 12.5 and the TSH is 2, which are within normal limits. So, what are we dealing with? Are we going to reassure and provide routine postnatal support? First thing is we need to understand if we have to formulate a management plan, we need to understand what is the diagnosis. So from the scenario, we understand that it is a case of postpartum depression. This postpartum depression will definitely be requiring a referral to a perinatal mental health team to take care of her at the earliest. So this is a case of severe postpartum depression with suicidal ideation. So we are going to refer her to a perinatal mental health team. Postpartum depression is seen in almost 10 to 15% of women. And whenever there is suicidal ideation, that means she requires an urgent psychiatric referral to a perinatal mental health team. The drugs that are usually administered are SSRIs like sertraline, but always the specialist must be involved in this management. Coming to the next scenario, we have Emma, a 35-year-old G2P2 who presents 3 weeks after postpartum with disorganized thoughts, erratic behavior, paranoid delusions. So right from the second line, we understand that this is a case of psychosis. Let's look further into the scenario. Her partner reports rapid mood changes, pressured speech, insomnia, and she states that her baby is possessed by demons. So delusions and hallucinations is again pointing towards psychosis. When the healthcare professionals attempt to examine the baby, she becomes agitated and screams that they are trying to harm the child. She has a history of brief depressive episodes in the past, but was never formally diagnosed. Her sister has a bipolar disorder. So again, we have a very strong family history here. And her mother was hospitalized for psychiatric illness after childbirth. A physical examination reveals no neurological abnormalities. Routine blood tests are normal. So what do we do? This is a case of postpartum psychosis and she needs an immediate admission. So where is our option there? Admission to mother and baby unit or emergency inpatient psychiatric admission without baby. So we have two options here. So are we going to admit her to an MBU or are we just need to admit her? We need to understand that though the woman has psychosis and delusion, we need to admit her under a mother and baby unit because the baby needs to be cared. This is a psychiatric emergency and this is seen in 1 to 2 per 1,000 deliveries. This woman requires an urgent admission to the MBU for the safety and for intensive treatment. Usually the first line management is going to be with drugs of antipsychotics like olanzapine or risperidone. Lithium is contraindicated in breastfeeding. Going on to the next scenario, we have Aisha, a 30-year-old woman who's delivered a healthy baby via cesarean section at 39 weeks. She presents 4 weeks later with excessive worry and constant fear that something bad is going to happen to her baby. She has some palpitation, shortness of breath, and chest tightness. But usually she is seen when the baby is sleeping. She admits that checking her baby's breathing every few minutes and frequently waking up in panic. She also struggles to fall asleep even when the baby is sleeping peacefully. She is exclusively breastfeeding and wants treatment that is compatible with lactation. There is no history of psychiatric illness, but her sister has a history of generalized anxiety disorder. Apart from that, her examination and blood tests are remarkable. So, what are we dealing with here? We are dealing with an anxiety disorder who has got some panic attacks also. So, she will definitely need some medicines to help her control this anxiety disorder. The most common drug and the safest drug we use in postpartum is sertraline. Sertraline is the first line which is used in breastfeeding women. To offer an adjunct therapy, cognitive behavioral therapy is definitely effective. Going on to the next scenario, we have Lisa, a 22-year-old primary woman who presents 5 days postpartum with tearfulness, emotional lability, feeling of being overwhelmed. She cries several times a day but is unsure why. She reports feeling irritable and easily frustrated, especially when the baby cries. But she is denying any symptoms like persistent sadness, suicidal thought, or feelings of hopelessness. That means she can have postpartum blues. Looking further beyond, we understand that despite feeling exhausted, she is able to sleep properly, she is maintaining a good appetite, and she is bonding well with the baby. Moments of joy and bonding with her baby. Now, these are symptoms that we have to keep in mind that this is not a case of depression. But always she feels that she's worried about being a good mother. She is having a supportive partner and a family, but sometimes she is overwhelmed. She denies intrusive thoughts, panic attacks, or paranoid beliefs. Physical examination is normal. Her blood test just shows mild anemia. So we are dealing with postpartum blues. What do we do with them? We are just going to reassure them and advise them a routine postnatal support. This is the most common presentation that is seen in the postpartum period with related to mental health. This is seen in 50 to 80% of the women. It peaks at around 3 to 5 days postpartum. It is usually self-limiting. It resolves in 2 weeks. Most of the time, these women do not require any kind of medication. Just reassurance and support will be enough. So next, we are going to deal with some scenarios which involves management of postpartum hemorrhage. So let's look into the first scenario. We have Maria, a 27-year-old G2P2, delivered a healthy baby via spontaneous vaginal delivery at 39 plus 2 weeks. Within 10 minutes, she has heavy vaginal bleeding. Uterus is soft and boggy. Fundus is above the umbilicus. The fundal massage is initiated and a bolus of IV oxytocin is administered. Following even oxytocin, the bleeding is persisting. Additional uterotonics, including ergometrin carboperas, are given without significant improvement. But right now, she's still hemodynamically stable. BP is 110/70, heart rate is 98, hemoglobin is 8.5, and coagulation is normal. So, medical management of atonic uterus is started. Given that the uterotonics have failed, what is the most appropriate next step? We know for any case of postpartum hemorrhage, for atonic causes, we are going to start with uterotonics. Now, if uterotonics have failed, what else can be done? So, looking at the options that are available here, ergometrin, uterine compression, IV oxytocin, carboprost, all this has been given. Of course, there are other drugs like misoprostol, tranexamic acid, are other options. But they have been mentioning in the question that the uterotonics have failed. That means we need to go for Bakri balloon tamponade as the next step. Scenario 2, we have Aisha, a 32-year-old G3P2 who underwent an emergency cesarean section at 37 plus 4 weeks. And the reason being placental abruption with fetal distress. 40 minutes post-surgery, she develops massive vaginal bleeding when the blood loss is more than 1.8 liters. BP is 80/50, heart rate is 132. She is pale, drowsy, and tachypneic. That means she is hemodynamically unstable. Coagulation profile shows prolonged INR, low fibrinogen, and thrombocytopenia. That means there is DIC. So despite IV oxytocin, carboperas, and Trenexa, bleeding is still there. She's already received 2 units of packed red blood cells. So what is the next thing we are going to do? In this case of DIC requires correction of the coagulation system. So if PRBs have already been given, the next best option is to go in with a fresh frozen plasma. Going to scenario 3. Elena, a 35-year-old G5P4 with the history of placenta previa, underwent an elective cesarean section at 37 weeks. During surgery, there's massive blood loss, more than 2.5 liters, poor myometrial contraction around the placental bed despite giving the medications. Bakri balloon was given, Trenexa was given, the bleeding is still continuing. Now BP is 70/40, tachycardia 140, worsening acidosis and hypovolemic shock. Though the blood transfusions are ongoing, she is becoming increasingly unstable. So what do we do? What is the most appropriate next step? That means we have to control the bleeding. And the best step here, when everything has not responded or not corrected her postpartum hemorrhage, then we need to go in with a hysterectomy. So hysterectomy is kept as a last reserve, especially when the woman is not responding to any of the medical or surgical managements. Going on to the last AMQ, we have some scenarios of neonatal resuscitation, and let's see what are we going to do with them. So scenario 1, we have Sarah, a 27-year-old primey who delivers a baby boy at 30 plus 2 weeks via emergency cesarean section due to severe preeclampsia and absent end diastolic flow on umbilical artery Doppler. The baby is limp, apneic, has poor muscle tone. Heart rate is 50 after 30 seconds of effective ventilation, and SpO2 is 70% despite a positive pressure ventilation with room air. Blood gas shows severe metabolic acidosis. Now, what is the next best step in neonatal resuscitation? So, what are the important parameters we need to keep in mind? First is it is a preterm baby. Secondly, heart rate is 50 and SpO2 is 70. So despite PPV with room air, and the baby has got severe metabolic acidosis. That means it is time we have to give the baby adrenaline via umbilical venous catheter. So what are the important points? The baby is a preterm baby, non-vigorous, heart rate less than 60. So whenever the heart rate is less than 60, even after 30 seconds, chest compressions and adrenaline must be given. Going on to the next scenario, James is a 36-week-old newborn born to a 35-year-old G3P2 via spontaneous vaginal delivery. Pregnancy was complicated by maternal chorioamnitis. So that itself must give us a suspicion whether the baby has sepsis. The baby is lethargic, tachypneic, weak cry. The capillary refill time is 5 seconds and the blood gas shows metabolic acidosis. A septic screen is taken, but it is pending. So what is the most appropriate next step? We are going to give the baby IV antibiotics. And why is it so? Because a maternal history of chorioamnitis and the baby being lethargic and with a very poor cry in the postpartum period is suggestive of neonatal sepsis. And that is why we start with giving IV antibiotics. So let us look at the next question. So IV antibiotics will be given to this baby as as the baby has a clinical suspicion of neonatal sepsis. Going on to the next scenario. We have Leo, who's a 41-week-old term baby born via vacuum-assisted vaginal delivery due to prolonged second stage of labor. At birth, the baby is not breathing, no respiratory effort, heart rate is 40. So it is definitely less than 60 here. Resuscitation team has already provided tactile stimulation, suctioning, 30 seconds of effective positive pressure ventilation with 21% oxygen. That means with room air, but the heart rate is still less than 60. So what is the next thing we are going to do? Even after giving a PPV, if the heart rate is less than 60, that is an indication of starting immediate chest compressions. A newborn whose heart rate is less than 60 despite 30 seconds of adequate PPV requires chest compression, and the ratio is going to be 3:1. So this completes this session or the module postpartum problems. I hope this will certainly improve your preparation for the upcoming EPCOG examinations. Do follow our YouTube channel for more such videos and stay updated. All the very best for your upcoming EPCOG Part 1 exams.